It's a great pleasure to give you this title and this talk, but I wanted to be slightly controversial and really, in essence, be a warm-up act for Mark Nelson. And the title you've given me is Special Considerations Before, During and After Therapy. I have to tell you, these are my disclosures. I think London's having a pretty tough time at the moment, and I'm a little bit snarky, and I don't think that there are very many special considerations we need to talk about in the consideration of DAA therapy. We're in a very interesting environment, it's very exciting, and I would also say that it's really about where you've come from and your expectations about DAA therapy. There are bureaucratic issues, but really we have very effective tools now, and it's really access and upscaling that is really the issue. And I think Jürgen highlighted that in his nice overview of the EASL meeting. Again, this is a slide that you will have seen many times before. This is from Heine, and this is demonstrating the panoply of different options we have now available for us in the treatment for hepatitis C. We really have witnessed a revolution in the availability and the research that's gone around this, and people around the room have really driven this transformational change for a group of patients. But we certainly have a different task now that we have these drugs licensed. There is access and there are broader issues, and certainly the elimination session later is going to be extremely relevant. One of the issues I do want to pick up, and I think it's important to discuss in the world of HIV, you've been extremely strong in your advocacy, you've been very focused, access to drugs, awareness, meetings such as this and programs around the world have really taken a broader view. We need to be very careful that we understand the slings and the arrows around issues such as a Cochrane review, which is really very limited in its remit, and how that could be translated out to sort of the community and through the media. So I wonder if this should get some discussion, but it really tells us that actually there are some hurdles from a societal perspective about getting treatment for patients with hepatitis C. So it would be really interesting to see, are there any thoughts about this recent Cochrane publication? Again, a slide from my friend Heine, very clear cut. We all know this. In the world of treatment that we have today, we have a 95 to 100% SVR rate, cure rate, whether we think that's beneficial or not if you're a Cochrane reviewer. And in real life, we see those data sets really being replicated with a very good efficacy and very good safety for all populations. And I would suggest that there are really no special populations now when it comes to the treatment for hepatitis C. Again, just to address some of the issues that you've seen in that Cochrane review, which is very limited with regard to those registrational studies, there's a whole host and raft of evidence showing us that cure really is cure, that it can certainly make a positive impact in mortality associated from liver disease and progression, but also in non-liver disease-related mortality, and that those patients who have achieving SVR have a survival rate similar to the general population. So we really do need to keep making these points in the general environment when we're talking to commissioners, when we're talking about other environments, and when we're talking to patients. Because again, as Jürgen stated very clearly, whilst we have these tools, the upscaling of what we need to do to really deliver those WHO kind of recommendations and mandates is something that we haven't quite understood. We've got to really upscale at a very significant level, and we need to keep the quality within what we're doing. So this is really, from a clinician perspective, you have very good EASL guidelines. There are ASLD guidelines as well from my American colleagues, but we're in Europe and I'm still a European, so we'll go with the EASL guidelines. We know that there's real-world data that's there, but actually, certainly, in all environments, I think there's still a degree of bureaucracy associated with your decision around choice of therapy, and how you tailor that choice of therapy is really mandated around stage of liver disease, genotype, and the environment that you're in. So I'm going to summarize my talk in one slide, and I have to say I'm quite proud of this slide that I did this afternoon. So a Churchillian view, really it's very easy now. It's mostly easy for most of the patients unless it's complicated. And there are a few complicated situations that I'm going to really tease out, and I probably would like your help in some of the decisions that we certainly made. Again, this is an important comment about how we're approaching hepatitis C. We need to be much more comprehensive. You can see there's no red box around the treatment. It's really about the awareness, surveillance, harm reduction, screening, risk group, diagnostics, very much Jeff's involved in the point of care type of issue, and the standards of care as we upscale to a much, much bigger environment. None of this needs to be special. The different environments are going to take different ways to do this, but really that is where the thrust of where we should be focusing our efforts is at, and actually we have all the tools that we need to treat all the patients now. So really, what are the considerations that are really special at this moment in time? So you should imagine, if you're a treater in an ideal world, seeing all this data, going to EASL, going to ASLD, seeing patients, that your patient can be Ryan Gosling and that you're Emma Stone, and that it should be just a wonderful kind of play of you and the patient delivering this treatment and everyone getting a good outcome and everything going fine. And I think that is the majority of what we're seeing. But we're now going to have to go into more complicated populations. We're going to have to find those populations. We're going to have to educate those populations. And we're going to need to get them through a therapy and make sure that they're optimized afterwards. And I think that's the bit of the special that we need to think about in the context of this talk today. Because my personal view is, and the clinic is going right now with my colleague Mary Cannon, is that actually this is how I view hepatitis C DAA therapy from a provider and a patient perspective. 95% of the patients are just straight in and straight out like La La Land, but we will see patients who are really having multiple other issues that are not related to their hepatitis C, and their hepatitis C is not really a problem, and we're looking at them and talking to them and saying, look, we can cure you, this is really easy, we have great medications, they're very simple, and they're saying, my life is like Dante's Inferno, and I have loads of other issues. I don't know where I'm sleeping tonight, I don't know how I'm going to cope with all of these things. And oftentimes we're left at the end of the clinic on a Wednesday afternoon phoning 4 or 5 patients who've not turned up to pick up their medication or even to start treatment. And these are the patients that we've seen, that we've already gone through the bureaucracy for, that we've already taken through and who should be ready to start. And I'd be delighted if any of you in the room should tell us if we should do it in a different way, because it is somewhat frustrating in the environment that we're in now. We need to open up our kind of issues about any preconceptions about who we should be thinking about treatment. I don't think that the PWID population is a special population. I don't think the transplant population is a special population. We need to be much less judgmental and really adopt an Australian or elimination model and really be treating people without a risk of failure and being much more aggressive about what we do. But we certainly all bring some preconceptions to who should be getting what is quote-unquote, a 30K drug therapy that may not be providing benefits from a Cochrane review. So I thought, rather than giving you a didactic formal lecture, as Charles suggested that I do, I thought I'd give you a couple of real-life cases. This is a co-infection meeting, so I'm going to give you one of our cases that's going through treatment right now that Jeff is involved with. This is an HIV patient diagnosed in 1995. Don't worry, Mark, this is not one of yours, not one of ours that we share. HCV genotype 4, failed therapy previously, appropriately referred to liver transplant. You had a very nice talk about that today, and went through liver transplant in the expert hands of King's transplant team and did very, very well. But he's a normal individual. He is a poor clinic attender. He used to come because he had a very sensible girlfriend from Eastern Europe. He's from Eastern Europe. She came to her senses and left him a couple of years ago. He has a history of relapse into alcohol. He managed to not take his immunosuppression for a period of time, but he is now pretty stable. But his disease has very clearly continued to progress. He's been admitted with renal failure to another hospital in London that shall be nameless, with cryoglobulinemia, nephrotic range proteinuria. He's now on hemodialysis, and of course now he's got an accelerated post-transplant course, and he's cirrhotic. And we have some concerns about how well-preserved his cirrhotic status is. He's gone on to a CNI-sparing regimen of prednisolone and MMF, and he's on hemodialysis. So we get a slightly panicked call from the local HIV clinicians. We would have phoned you, Mark, but your phone is never on. It's always international. So we had to get involved with this patient. And the one thing we would say for him is that he's still managing to work. He's on hemodialysis 3 times a week. He is managing to re-engage with his system. He's a little bit of a rascal. There's no doubt about it. He's had a colorful life. My question to you is would you treat this patient now? I think he does actually fit, having said that there is no one who's special. This is a special patient. This is a patient who needs a little bit of thought. He's clearly not going to be a retransplant candidate, but we certainly should, if we're going to try and improve his renal disease or stop his inevitable decline, think about treatment for him. This is a slide showing you his creatinine. And oh, I forgot to tell you, because you're an HIV audience, you'd want to know that he has had, poor adherence to all meds at various times. To be fair to him, he had to go back to Eastern Europe because I think his father was unwell and dying, so he went off the radar completely. He's got multiple HIV drug resistance. Please don't ask me about it. And he's now on Truvada, dolutegravir, darunavir, and ritonavir. So what are his options? We have a panicky phone call from the team at another hospital, not Chelsea and Westminster. Should we treat him with the Merck regimen? Should we treat him with a sofosbuvir-based regimen? He is on dialysis. Should we treat him with ribavirin? Should we treat him with 3D, knowing that there may be a hint that he may have end-stage liver disease and may be pretty brittle with regard to his liver disease? And my question is really, is he going to turn up? We've known him, I've looked after him for 10 years. Are we going to get Sylvester to turn up, and is he going to come through? And how are we going to get him to sort himself out to do this? And actually, this is the bit that's important. It's the patients who are now really the important pieces of the package, because they've got to know what they're getting into. So this is where we're at. This is his drug-drug interactions. Of course, drug-drug interactions are going to be important, and you're going to hear about that. And we decided, with some toing and froing, that we'd go for sofosbuvir, ladipasvir, with a small dose of ribavirin regimen in a very careful, tentative, seen by a very senior consultant with transplant review, backup as required. And so far, he's doing well. But I think this is a special case, and I think these are few and far between, but they do highlight even those patients who have transplants may have adherence and attendance issues, and these are relevant to our day-to-day treatment issues when we want to deliver treatment. We have no plan B for this patient. We just thought we'd jump and give it a whirl. Here's another patient, and this is a much, much more similar patient to what we're seeing and what you're going to be seeing in your practice, whether it's in a community basis or a specialist practice. This is not Jeff Dushako. This is a patient, although the initials are the same. This is a genotype 3 patient who's been coming intermittently to King's since I've been a consultant at King's. He's had variable attendance. He is hepatitis B as well. He's E antigen positive. He's delta negative because we did check it. He has clearly got a FibroScan that's very elevated, and he's cirrhotic, and he has a degree of portal hypertension, we think, and there may, as you sense with that reading, be other things driving his current liver status. He has XIVDU, he's got mental health issues, he's got anxiety, and clearly these factor into anything that we're going to be doing for him. He has no vascular access at all, by the way, after having a long and distinguished history of IV drug use. There's only one nurse in the community bloodborne virus team that can take bloods from him from the neck, and it has to be arranged quite carefully before we do it. He is drinking a variable amount of alcohol, but he has managed to control it, but occasionally related to depression and other unsettling events, he can have some heavy bouts of excess. He has got external iliac and femoral vein thrombosis with severe post-thrombotic syndrome. He's got inflammatory arthritis, and he has 6 children. He came to clinic with his 3-month-old baby and his partner. And actually, we had to say, well, you turned up for clinic. This was a really good thing. Should we treat this patient or not? Both these patients are under the age of 50. They're all younger than Professor Nelson, and we think we should do the right thing for these patients. But these patients are what we're going to be seeing. The challenges of their psychosocial package are really what we now need to think about when we address treatment and we think about this. And I forgot to tell you, he had a GI bleed that we're not sure what was the etiology of this. We don't know whether this was a varicose bleed or anything else. They managed to get a hemoglobin, but he refused to stay for an endoscopy because of the access issues, and we don't even know whether he's got varices or portal hypertension. These are his medications. Professor Back at the back will let you go through those carefully. And of course, we went through the Liverpool website, which is a very good website. And of course, when you're thinking about treatment for patients, you need to go through and look at the issues around interactions. And this is really a phenomenal resource to help you decide what you need to do. This is this gentleman's bloods. We changed things around, and we decided to go for a soft val regimen for a genotype 3 patient. And we decided, because we had no way of monitoring him at all with regard to blood tests, we have no way at all, we're just going to try and see him when we can and get the community nurse to do his bloods, that we would not give him ribavirin, which I think is a risk, but I think is a calculated risk in the context that we don't know whether he's got significant portal hypertension or not. And yes, he has done pretty well to treatment week 8, and we did manage to get some bloods, and he does have an RNA that's not detected, and our fingers are crossed. But in essence, those two cases are really trying to highlight to you how you need to prepare patients before, how we need to actually find these patients, because clearly the transmission risk issues are very significant, and the diagnosed patients who used to come to clinic stringently and be delighted to see you for 5 minutes and wait for the next treatment, they're all being treated. We were on a conference call with Greg Dora yesterday, and he doesn't really have many HIV co-infected patients in his service anymore. Even the drug and alcohol services, they're saying that in Australia they've treated 70% of the patients that they're in their services already. So the scaling up that we now need to do is actually finding these patients, preparing them, and getting them in so that they can get through treatment. What about on-treatment monitoring? Again, my personal view is I think it's pretty boring now. We have safe medication. They have to come and pick up their meds, normally at 4 weeks. It's good to give them some positive reinforcement with an RNA, but really it doesn't change anything. It, I think, can be simplified. There's clearly opportunities with teleclinics, and certainly in the UK it's extremely over-bureaucratic, and it needs to simplify out, and there are newer protocols coming down the line where we need to really minimize our monitoring with regard to whatever environment we're seeing patients and we're treating them. You're bored of this because you've seen these slides now 3 times, but there has been a slight hysteria about hepatitis B in the context of DAA therapy and reactivation. This is generated from a very ungranular case series of 29 patients where we didn't even have hepatitis B status on the majority of these cases, but no doubt there were 3 serious complications in these patients, and so this has now become a huge focus for everybody. This is just random abstracts that you haven't seen but are important, where we have seen essentially now that hepatitis B reactivation can occur, but it's extremely rare, and it's unlikely to be an issue, certainly in those patients who are core antibody positive. And this is another abstract which is really seeing in red that there were no clinically significant episodes of reactivation. So I think this is a red herring. I think this is something that's not important, and being one of the junior partners in the EASL Hep B guideline panel, I got dumped with the section looking at this, which caused the most debate and arguments, and we took a very simplified approach. They're guidelines, they're not prescriptive. Obviously, if you're surface antigen, you should be treated and have disease, you should be treated for your hepatitis B. That we, in the context of a changing milieu of evidence, we thought that if you're a surface antigen, you should consider having prophylaxis whilst you're on DAA therapy. I think that will soften further. And we really wanted to suggest that those patients who are core positive should just have their LFTs monitored, and only if there was a rise in those LFTs would you then consider the idea of reactivation. And I think we've got an increasing level of comfort that this is not really a clinically significant scenario that we need to worry about. What about if we get to the end and we're getting to cure and we can see that we've achieved nirvana and we can see New York in the distance? Again, you're going to get an expert overview tomorrow of HCC and the issues of post-SVR management, really generated by a fairly, again, controversial publication from the Barcelona group with, I think, a very poor control group, which was very appropriately highlighted out with a nice letter from the Craxi group, and a lot of ambiguity and opaqueness about the data sets that we see of, is this a real issue or is this not a real issue? When the FDA get involved, then clearly it starts to become something that is more concerning. Data that I think is worth seeing. You're going to see much, much more of this tomorrow, but I like this presentation from EASL. This is the Scottish group. They're still part of the UK, and they're demonstrating that if you control for factors, baseline factors, that increase the risk of HCC, that then there isn't an increased risk in the DAA era compared to the interferon era. These patients were older, they'd had previous attempts at therapy, they had thrombocytopenia, and they had more advanced liver disease. Again, another publication, and this is from a Sicilian cohort, and this is looking again and showing that SVR was not associated with an increased risk of HCC, and I think it's to do with what the baseline characteristics are, what your comparison population is, but I think it does have legs and it continues to run, and in our transplant service for assessment, we have 2 patients in right now going for assessment, both achieving an SVR related to DAA therapy and within 12 months developing HCC. Yes, there's maybe a biological plausibility around the potential link, but certainly I don't think I'm swayed by the evidence to say that this is something significant as a DAA-related issue. I just really wanted to push again the idea of simplifying therapy as we push and have to scale up significantly. I think we're still in a rather comfortable zone with regard to the type of patients that we're treating. I think a very important point that we're seeing from some of the data that's coming out of Australia is that if someone has a diagnosis of hepatitis C, you need to get them into treatment quickly. And you may lose some of your attendance and your follow-up, but actually the risk from a public health perspective with regard to transmission, but also the engagement from a patient will actually dissipate. So the faster you can get in with treatment as soon as you can after a diagnosis may be more elegant. And this is a nice study from Greg Dorey's group and the Australian group showing a more advanced population of patients with regard to drug use, with nearly 45% of them actively injecting and really getting excellent outcomes with regard to DAA therapy. So we have the therapy. There aren't really very many special considerations. We just need to make sure the patients are prepared in the right way. We have to accept the potential issues after therapy of reinfection. So I think it's about optimization, all of the simple harm reduction measures and the public health issues. So as hardcore transplant hepatologists, we need to really adopt a different way of thinking and addressing the longer term outcomes. And our rescue options you're going to hear about with regard to other things, but actually we're seeing newer data for those who have failed, and we do have now a panoply of potential options that currently, by the way, aren't even available for us in the NHS environment, and they do need to come through to patients, because patients who fail often have slightly more advanced disease and have a clinical impairment. So if patients fail, you will have that discussion now, but baseline testing and other things will mandate what classes of drugs you're going to use, and that's going to be important. Lastly, special considerations, the issues around end-stage advanced liver disease and whether you can regenerate or salvage patients. We've been very much involved in this data set with Luca Belli. We did not contribute our patients to that because we did not feel we could suspend patients or delist them in our listing environment, but there is a suggestion that a proportion of patients may improve and may not require transplantation, and there's good evidence now to show that there's been a significant drop in the listing for hepatitis C for transplantation, and certainly a 50% decrease in the UK for those patients with an etiology of hepatitis C coming through for transplantation. Just a simple slide to show you that hepatitis C is not often, just like my case, Jeff, not GD, Jeff, but the case who has other issues driving. This is a real photograph from Northumberland from when I was a registrar up there, and I do think we need to be very cognizant in our monoinfected and our co-infected populations of not just thinking about the hepatitis C and thinking about getting them to a cure, but addressing the other drivers of liver disease, whether it's NAFLD and particularly whether it's related to alcohol. And I do think the post-SVR optimization of health is going to be a significant undertaking as we take on an improving group of patients who are getting a cure. So this is my summary. So I think you've got to really focus now. The special considerations is that actually we need to make this simple for patients. We need to get their understanding. We need to get their contact details. We need to make sure we have a model of care that is easy for them to turn up to, that we're providing them with a short time from diagnosis to treatment, that we're giving them the whole package of care, and that we've got the logistics right to treat the patient. The second patient is really, really quite involved in his care because His partner is coming for their postnatal visits with his child on the same day he comes to clinic, so he really can't escape coming to clinic to see me or Mary. Can they turn up? Baseline fibrosis, genotype. Obviously, you're going to look at DDIs, and Professor Back, apart from his choice of football team, is an expert in this area. HBV status, I think, is a red herring. The monitoring on treatment now, I think, is getting simpler, and we're really talking about adherence. And I do personally feel that the HCC story is, again, a little bit overhyped. I do think the pattern of recurrence or the pattern of disease may be different with regard to post-DAA, but I personally am not convinced by the data as it stands now, and I do think we need to focus on post-SVR health and other drivers of liver morbidity. Thank you very much for your attention.